So this evidence that we are talking about comes primarily from research. If it does not come from research, it will have limitations. Okay, expert opinions, you can see that they are at the base here. It is evidence, but at the base, meaning that it is not good quality. The quality of evidence is actually low. But when you move further to mechanistic studies are those studies that investigate, for example, how a particular phenomena occurs. How, for example, a research that is interested in how cells actually divide, how a particular process takes place. These are mechanistic studies. You move to case control. You move to case reports, case studies, case series. These ones give you some evidence, but not the best evidence. But as you move up to randomized controlled trials, you have the best evidence that you can always use. So we are basically saying that evidence has to come from research. What we often get from research is objective evidence. Objective evidence is where we often use the word empirical evidence, that okay, the measurement tools are the appropriate ones and the right procedures have been followed such that you have objective results. In that, these results are devoid of opinions or biases, or if the biases are there, they are actually minimal. Now, when we talk about subjective evidence, or evidence that is coming from subjective sources, usually the opinions, expert consensus, whatever you can call it, this will have biases, so we cannot say it is objective, but that definitely is subjective. But when we look at quantitative research and qualitative research, quantitative research gives us quantitative research gives us objective evidence, and then qualitative research gives us subjective. What people feel, their perceptions, their attitudes, that is subjective. When you go and measure prevalence, prevalence of a particular condition, you have very good measurement tools, valid and reliable tools. You're going to get objective data, and the findings generally are going to be, you're going to have findings that are objective. Okay? So, however, not very important, that lack of evidence does not mean that you cannot make a very good decision. Okay, lack of evidence does not always mean that you cannot make a very good decision. And we actually did say that sometimes the evidence is not actually perfect, or sometimes the evidence is not there. But you can always make a good decision on the course of action that you can take. So absence of excellent evidence should not be a justification for you to make stupid, unworthy decisions. So in terms of scientific evidence, in terms of public health, remember that for justification of whatever problem that you are going to address using any public health intervention, you need to quantify. You need to tell us what the problem is, where is it happening, who is being affected, what we basically term as descriptive epidemiology. Descriptive epidemiology tells us who is being affected, where, the time, the place, okay, time and place, and then the person, okay, who, the individuals or the groups of people. So usually the first evidence that we want, it basically rotates around telling us about the problem. So type 1 evidence basically defines the problem, and we are basically looking at causes, burden, and the preventability. Okay, something needs to be done about a particular problem. So, for example, if you want to convince people to allocate money to have an intervention to address youth smoking shisha, you need to give us the numbers. Okay? You say that people are smoking shisha, they are not going to school, every money that they get, this is causing them to get respiratory problems. The quantification, giving us the numbers for us to basically wake up and say, oh, we need to do something. That is evidence, type 1. And then type 2 is, okay, you need to make a decision on what needs to be done. Do these people need to be talked to through the radio? Do we need to go to the schools? Do we need to talk to the parents? What do we need to do? So you have different interventions. Now, which of these interventions work? That is type 2 evidence. Which of these interventions can actually work? This is what we need to do. That type of evidence is type 2. And in type 3 is contextual implementation. This is where we have a problem. This is where we have a lot of problems in terms of public health. That, yes, an intervention can be effective in a particular place. For example, let us say, I think in Uganda, they approved the policy of vaccinating youngers who have not had sexual encounters against the human papilloma virus, which is associated with cervical cancer. And it is basically working. Can you do that in South Sudan? It can be very tricky. Very tricky. Okay, because of cultural factors, because of many things, the geographical distribution, how will you gather this? How will you convince many problems? So the implementation, the context around the implementation, something which works somewhere may not work in your area. So how should we do it? If you have the answer to how can we do it, very, very good. In public health in generally, that is where we have limited research. Okay, implementation research. This is where the gap is always. But we know what works somewhere, but we don't know whether what has worked somewhere can work in our context. So contextual variations or variables, they can be the nature of the people, the nature of the communities, the nature of the intervention, cultural factors, political factors, economic factors will lead to work. So it means you need to look at multiple factors. Okay, and often if you have carried out research, you may get an understanding on how some of these interventions can work. We can have interventions in South Sudan that work very well, but you transfer them to another country and they may not really work. What can help is what we often term as triangulation. That, you see, the evidence that you have gotten in one aspect may not be enough. You may need to get evidence from multiple sources because, for example, when you take perspectives using, for example, the quantitative lens, there is something that you're missing. You're missing people's constructed knowledge or even people's experiences about particular interventions. And that can actually be very, very rich. So that is why we often talk about mixed methods of research, because we can combine quantitative and qualitative. So the qualitative part, you interview different people because they will not look at a particular phenomena in the same way. People have their own experiences and they have their own constructed knowledge, socially constructed knowledge about particular social phenomena, that these insights can actually be very useful. And that is why triangulation is very, very important, especially in qualitative research. But also, we can justify having combined methods because of the fact that when we get sources from multiple, we get evidence from multiple sources can actually be very useful. So when we combine these two, we do not only answer the descriptive part, we can also answer the analytical part. What, why, how, and then plus the other who, where, and what. These can all be answered if you do triangulation. So triangulation is about sourcing for data from multiple sources, okay, regardless of the problem that you're dealing with. Now, there is a debate on what forms best evidence. People who are in the qualitative world will always oppose the people who prefer quantitative research. So you have a debate. The debate largely has been that people think that quantitative research actually gives you the best level of evidence. And that's why when you look at the hierarchy of evidence, you see that randomized control trials, cohort studies, and things like that, they are up there because they give you the best level of evidence, or they give you good or better quality of evidence that you can ever think about. Now, that kind of thinking is turning towards what we term as positivist approaches. With positivist, it's about measurements, about objective data, no bias, making sure that you don't have bias. That is the positivist way. So the focus is a lot on randomized control trials and other rigorously managed research designs. But we also have people on the other side that say subjective knowledge is actually also very important. Subjective knowledge is also very important. And as we speak today, there is general consensus in the academia that, okay, both are equally important. Now, let me bring this example that you see that you can go to the lab, develop a drug, and that drug works. For you to develop a drug and you are proven that it works and all of things, that is mainly clinical trials, randomized clinical trials are the ones that will produce for you this drug that works. Now, you have developed this drug, but you take it to the patient, and the patient is not adhering to this drug. Quantitative methods may not give you an understanding of why this patient is not taking this drug. But if you sit down on a one-on-one interview, through qualitative research approaches, you can get better understanding of why this patient is not taking the drug. So you can see that you still need qualitative research to back up quantitative, but you also sometimes need the quantitative to back up the qualitative. So it is very important that you understand that we have people in the academia that are oriented either to quantitative or qualitative, but equally both of them are actually very important. Even you as a person, you'll be leaning more towards a particular angle, and that is still okay. Now, the challenge that we face in low resource settings is that, okay, we may want this very good research, but do we have the resources, the funds, the expertise to basically do this? If we don't invest in research, then definitely we are not going to have published work. And what we do will always be because of the fact that this research, the research that we actually consume is coming from European countries. So that kind of research is not contextually sensitive. It does not take into cultural context, our own local settings, and it's what we are relying on because we are not investing in our own research processes. So public health, as a field, you need to know how to apply evidence. And that is why in some countries, when you graduate as a person who has, let us say, bachelor's in public health, you need to get what we call certified, such that you can become a certified public health professional or practitioner. Now, when you look at these countries that do this certification, you realize that actually they want to know whether you have competences in the use of evidence. So it is evidence-based public health is a competence that is assessed for you to be certified. And what they basically look at is, do you know what quality evidence is? Can you apply it? Can you evaluate evidence? And then, do you have competences in using community health assessments, improvement plans, strategic plans to basically improve population health? Okay, so that therefore means that evidence-based practice in public health is very, very vital, because you will need to convince a number of people that there is evidence that this intervention works. So who are the people that you always have to interface with? You will interface with government officials who are the policy makers, and they are the ones who have the money. So if you cannot present to them evidence in a way that they can understand, your evidence will always end on your computer, in your published research article, and it will not have real impact on the ground. So you need to work for all audiences, and that is where communication becomes very important. How can you communicate to politicians? How can you communicate to communities? How can you communicate to your fellow researchers? And how can you communicate to your fellow public health professionals? So you don't work alone.